I would now like to invite Will, Andrea and Ed, the other speakers, up from this session for the Q&A. I would encourage you all to submit questions using the QR code on the slide to the VVox. If you'd like a question asked to a particular person, if you could please indicate which person, that would be really helpful. We also have some roaming mics if anyone is struggling with internet connection. So if you'd like to use one of those, please raise your hands and I will do my best to monitor both the VVox and the room. Okay, Andrea, you're up first. I'm going to take my chair's privilege because the one at the top of the screen is for me. But your question is, does the target trial emulation Andrea presented only focus on the discontinuity at age 50? How far can it be extended to a wider age band?
Yeah, it's a good question. So just to clarify, so this isn't exactly a target trial emulation, although like a target trial emulation, the approach I demonstrated can be used to estimate causal effects. So with any statistical analysis, an important question is, well, who do these results actually apply to and who are they generalizable to? So in particular with the regression discontinuity, the results apply specifically to people right at the threshold, so around that 50-year age cutoff. Logically, we can assume that if we do find an effect, that it does apply a little bit wider. How wide you can go in terms of generalizing these results to other age groups, probably not too far, but it is an important thing with any analysis of thinking who exactly does this apply to. And it is specifically to people around the threshold.
Great, thank you. So I'll take the next question. So it says, regarding post-COVID events, so the pre-vaccination group was wild type alpha while the others were delta. Was this taken into account in the analyses, or is there a reason to believe that different variants may cause different post-COVID events? So this was actually one of the things that we were interested in. We split the cohorts in that way, partly because of the vaccination, but also because of the different COVID variants. So the best way to compare the variants is to look at the pre-vaccination group that were exposed to wild type alpha and were unvaccinated at the point that they got their COVID infection, and compare them to the unvaccinated cohort who were also unvaccinated at the time that they got their infection, but got the Delta variant. And as you saw on the plots, we did get some small differences in those two groups for some outcomes, but nothing consistent across the range of outcomes that we looked at. Okay, this question doesn't have a specific person. Perhaps Will, it does ask about data access. So do you have access to time as well as date of vaccinations? Some data suggesting effects with COVID, and something might be modifiable if held for other vaccines too.
So yes, we have date of vaccination and type of vaccination. Without date, you really couldn't do very much at all. If the chances of an event occurring, of a COVID-related event occurring after someone vaccinated in April 2021, say, versus someone vaccinated in December 2021 are going to be very, very different, because the number of infections circulating at the time was very different in those two dates. So we need dates, absolutely, and we have access to that. I'm sorry, what was the rest of the question?
It says some data suggesting effects with COVID and something that could be modifiable if held for other vaccines too.
Is it about time of day? Time.
Ah, time of day. Date times, they get you, don't they? We don't have that level of granularity, but I think it's available when collected, but I don't think it's exposed in the database that we have. If it was a particularly interesting question, we could, and I'm looking at Amir, we could potentially do the IG work to access time of vaccination. That's an interesting question that I wasn't aware of, that sort of connection, but the potential is there, but I don't think it was something we'd be able to do immediately.
Okay, so this next question, again, anyone on the panel, and I'll start with Ed in the interest of fairness. Once open safely can be used to ask questions not related to COVID, what other types of diseases could these techniques be used to analyse?
Well, I think in my slides, I kind of put the challenges as can we support contemporary policy decisions and can we support vaccine delivery? So if we look today, we have the ongoing RSV rollout in over 75s and to pregnant populations. So those would be the imminent questions where if we can demonstrate effectiveness and safety in those rollouts, then that can help feed into policy decisions. And also in the case of RSV at the moment, it's kind of a one vaccine for the future, but actually if there's some groups that the protection wanes, then you'd want to prioritize those for a potential extra dose. So these are open questions that can support policy. And similar with shingles, we're sort of seeing this new rollout. So these are sort of active areas where the policy's recently changed, whereas really, the flu vaccination has been around for a long time, and there's not really active questions related to that. So I think it's where the policy has changed, but then the other element is, we've seen declining routine vaccination coverage across the UK year on year. We have groups that have been offered 2 vaccine doses in spring and autumn campaigns, and the sense of, with each campaign, a little bit of an attrition of that vaccine coverage. And what can we do to sort of support this? And I think if we can show people data saying that vaccine campaign that you got in the spring, it was safe and it continued to offer protection to people in your clinical subgroup and in your demographic subgroup, then we could help sort of push back and help turn the tide of that declining vaccine coverage. So I think those are the 2 issues where we can sort of support ongoing policy decisions, but also try to show people data in the format that they want to see it that improves their confidence and engagement in vaccination.
Thanks, Ed. Is there any other regression discontinuities you've dreamed up?
Yeah, so the methods that I showed, they could be used to evaluate really any sort of intervention which is based on a threshold effect. So for instance, if we prescribe, for instance, statins to people with certain lipid levels, often there's a cutoff, so people with a level over a certain value, should be prescribed a statin, for instance. So a scenario like that, we could evaluate, well, what is the impact of being offered a statin on health outcomes, which could be cardiovascular events or anything like that. So anything where you do have that threshold effect, obviously it doesn't have to be age, it doesn't have to be COVID vaccines, it could be any vaccine. So there's really a lot of opportunities to do this kind of work because there's so many different policies and interventions being introduced at the population level that are ripe for being evaluated. Yeah.
Thanks, Andrea. Okay, another question for myself. So it says you've shown very nicely increased risk of various events following several events following COVID, but what is the risk after other severe hospitalizations with other infections like bacterial pneumonia? i.e., how much is it COVID versus severe infection in general, particularly post-vaccination? So this is a really important question and something that we have not answered yet. I think it is really important context how much these things are elevated following other infections. We started with COVID infection because of the restrictions in open safely at the time, but also that our work was funded by the national core studies, which were very COVID focused. But I think this is really important context that I would really like to add. The good news is, to plug the reusable action workshop tomorrow, all of this has been coded up in a reusable action and it's very flexible. So to switch out from a COVID infection to another exposure would be easy to do. So I'm hoping it's something that we will do soon. Okay. How did you handle the variation in coding amongst GPs early in the pandemic, where some people had suspected COVID recorded but never a definitive diagnosis? I think this one's also directed at me. So early on in the pandemic, well, for the entirety of the study, we used COVID confirmed by your GP or hospitalization with COVID death with COVID, and then when we had it, COVID testing data. So it's just the very, very first part of the pre-vaccination cohort between the 1st of January 2020 and the availability of mass testing in May, where we might be missing some people who had COVID and may or may not have known that they had it.
Can I add a point just
Yes.
more generally about sort of the because I think that question alludes to the fact that we've had various phases of data. One was when we had lots of worry about this rising wave, but not very much testing going on. So that's kind of this issue we just Venecia's just discussed. Then we have the period of mass testing where people are able to take lateral flows and submit it via a QR code and it go onto your NHS record for kind of a year or so, and then we have the halting of that and this kind of go back to the sort of dark matter of recent epidemic waves. And so I think if we kind of look, there's an opportunity. Lots of the work we've talked about is kind of being done reactively in the moment to ask a contemporary question, but there's also a potential to look back and use those different phases where, unprecedented population testing, we can look at questions about vaccine effectiveness for COVID that we won't be able to do again. And so I think there's sort of, after the dust has settled, analyses that can be done that sort of harness those different phases of data.
Thanks, Ed. So we are approaching the end of this session, so I'm going to combine two questions and ask for a final word from each of our panel members. So Jenny Brooker has asked to all what other information data would allow you to go further with your analyses. And somebody else has asked, how complete is vaccine information in open safely? So any thoughts about the data you have and the data that you would like?
There's a long list of things that people, ourselves and many collaborators have expressed an interest in having access to. I mean, are there any specific examples that you would like for your...
Sure. The top of the list would be hospital PCR tests for respiratory diseases that to define severe outcomes for effectiveness studies. So if we can have one.
Yeah, you can have one each. Will, would you like
well, I can't think of anything off the top of my head. I mean, for the vaccine work, I mean, I've worked with a lot of studies, and I've been incredibly lucky in the research that I've wanted to do has been facilitated by the data that we had, and there weren't so many. There was things that we wanted that we had no hope of getting that just weren't not being recorded anywhere, like infection. Just people get infected all the time, and we don't record that information. But and that would be great, but we can't. That's an impossible goal. So the work we did, we were just incredibly lucky that none of the things that we could have, but we didn't, were actually needed.
Andrea?
Yeah, I mean, I'll agree with Will, because I think the data would be nice to have are data that really don't exist, at least in an accurate and a complete way. So around infections, it'd be really great to be able to look at, mild to moderate COVID infection instead of just having to focus on these severe outcomes. Mm-hmm. But it's not that the data exists and we don't have it. It's the fact that they don't exist anywhere, and it's very hard to capture that in electronic health records. So yes, I agree with what you said.
Yeah, I would also echo that. I think the biggest limitation of our work has been a lack of symptom data, but it doesn't exist to have. Okay, that brings us to 11:30. Thank you for all of the questions that you've posted on the VVox, and for listening, and for attending the fire alarm so nicely. There is now coffee outside for us all to enjoy. So thanks again.